Good evening, everybody. I'm Robin Young. I'm publisher of Orthopedics This Week, and thank you all for joining tonight's masterclass on facet joint replacement. Tonight, it's all about clinical data, and I'm particularly pleased to say we will be reviewing a notably well-designed, prospective, randomized, multi-center controlled study. We are joined this evening by our masterclass faculty, Dr. Mike Steinmetz from Cleveland Clinic and Dr. Bill Welch from the University of Pennsylvania. Together, they will dive into the details of this pivotal FDA study, which compares the TOPS facet replacement system developed and manufactured by Premia Spine to a traditional TLIF procedure for the treatment of degenerative spondylolisthesis with spinal stenosis. But before I more formally introduce our master faculty, let me share with you some background on the TOPS facet replacement implant. The TOPS system is an alternative to traditional lumbar spine fusions. It's indicated for grade 1 spondylolisthesis and lumbar spinal stenosis. It is a pedicle screw mounted implant with a titanium assembly. The polycarbonate urethane boot encases the articulating joints of the implant. The implant stabilizes the spine and allows controlled physiologic motion, plus 8 degrees in flexion, minus 2 degrees in extension, 5 degrees in lateral bending, and 1.5 degrees in axial rotation. And most importantly, it blocks sagittal translation like a native facet joint. Just like fusion, the surgeon removes all bone and soft tissue that press on the nerves and generates pain, then places the TOPS device, which replaces the facet joints and the posterior elements following decompression. The internal joint mechanism of the implant blocks the shear forces that cause spondylolisthesis while allowing normal twisting and bending. Now to our esteemed faculty. Dr. Michael Steinmetz is chairman of the Department of Neurosurgery at Cleveland Clinic. He is the professor and chairman of neurologic surgery at Cleveland Clinic, Lerner College of Medicine at Case Western Reserve University. His areas of expertise and clinical and research interests are complex spine surgery, minimally invasive surgery, spine trauma, and spinal cord injury. Dr. Steinmetz received his medical degree from Texas Tech University School of Medicine, interned in general surgery at the University of New Mexico, and completed his residency at Cleveland Clinic Department of Neurosurgery. He is the author of more than 200 articles in leading medical journals and has contributed over 60 chapters to the body of surgical spine care literature. Dr. Steinmetz is either co-author or editor of five spine surgery textbooks. He's the deputy editor for the Spine Journal and senior chairman of the editorial board of Journal of Neurosurgery, Spine, World Neurosurgery, Operative Neurosurgery, and is a reviewer for several additional journals. Dr. Steinmetz is actively involved in many neurosurgery and spine surgery professional societies, which is kind of an alphabet soup. He serves on the executive committee of CNS, ANS, SMISS, NASS, and LSRS. He recently served as the program chair for the 2021 North American Spine Society annual meeting, 2022 LSRS, and the 2022 SMISS meeting. Our next faculty member is Dr. Bill Welch. He is the tenured professor of orthopedic and neurosurgery at the Perelman School of Medicine, University of Pennsylvania, and vice chairman of academic affairs, also in the Department of Neurosurgery. He is chairman, Department of Neurosurgery at Pennsylvania Hospital, where he also serves as the medical director of the Spine Center. Dr. Welch is also co-director of the Catherine Sharp Biomechanics Lab. His medical degree comes from the State University of New York as part of the 6-year medical school program with the City College of New York. He interned in general surgery and completed his residency at the University of Rochester. His fellowships were in neuro-oncology and spine surgery at the Albert Einstein College of Medicine at Montefiore Medical Center and Weiler Hospital. He is an active spine surgeon, investigator, and educator. He's authored several hundred scientific articles and book chapters. He is the section editor, neurosurgery on JACS. He is elected to the American College of Surgeons Academy of Master Surgeon Educators, participates in the ACS medical education program, and is former chair of the ACS Neurosurgery Advisory Council. Finally, he did attain the rank of Lieutenant Commander at the U.S. Naval Reserve, from where he was honorably discharged in 1993. It is truly my pleasure and a distinct honor to invite Dr. Welch, Bill, to please take our program on from here.
Thank you for that beautiful introduction. I just want to editorialize for 1 second. I was walking through one of the CNS or AANS meetings literally 25 years ago, and we came across the booth where TOPS was being displayed. Wasn't the exact current iteration, but was close to the current iteration. And I looked at one of the engineers who was representing the project and the product, and I just absolutely was enthralled by the concept and by the design and by the potential for the product. And I've had an interest in it literally for 2 decades now. And it's just an absolute pleasure to have been on the study and to see the study coming through fruition. I just want to give the company and all the researchers and all the physicians and frankly, all the patients who participated credit for seeing it through to what I believe is going to be a very successful conclusion. So just on behalf of all of us, thank you for that. And thank you to the company for getting the funding and seeing it through. So Mike and I are going to summarize our personal experiences and the study for the most part in about the next 25 minutes or so. I just want to review in an overview that the TOPS study was designed to have up to 500 patients. There was an analysis for superiority to be done at 300 and 400 patients. Patients were prospectively randomized 2-to-1 between TOPS and TLIF. The products used in the TLIF, the spacers, cages, and the pedicle screw instrumentation was either from Medtronic or DePuy Synthes. Now, importantly, the primary indication for surgery was single-level degenerative spondylolisthesis with moderate to severe spinal stenosis, obviously all very symptomatic. That made randomization a little difficult because the number of patients just having single-level disease, of course, is lower than the number of patients having multi-level disease, but the physicians were able to get the study completed. And what we're going to see today is the data representing the first look at superiority, not non-inferiority, but actual superiority. This is done with 302 patients enrolled, and it's based on the range of primary and secondary endpoints, which we will review. And again, the single level pathology between L2 and L5, between 35 and 80 years old. The ODI had to be at least 40, significant pain, and the patients had to have predominant leg pain as opposed to back pain. BMI could not be greater than 40, and 1 level disease with a grade 1 spondylolisthesis. The patients could not have undergone a significant prior surgery, that is to say, laminectomies or even significant discectomies, or they would have been excluded from the trial. So the next slide, please. The FDA, of course, wants a homogeneous patient population, and they want a heterogeneous surgeon population to make sure that the device that they're testing is going to be applicable across the United States. And this is a representation of the 37 clinical IDE sites. I think it's a very good geographic representation, and spread across the United States, and it's divided up between academic practices and between private practices. And then if you look at the specialties, it's well divided between neurosurgeons and orthopedic surgeons. And again, it's divided between multi-surgeon practices and single practitioner practices. So I think this is truly a very heterogeneous surgeon population with good representation of orthopedic surgeons and neurosurgeons, single surgeon practices, multi-group practices, private practices, as well as academic practices. The baseline demographics of the patients were very important and very similar. This was a very large group that was studied. The average age was between 63 and 64. You can see the height and weight, but you can certainly just get a feel looking at either the p-values or the raw statistics themselves. These patients were extremely well balanced with regards to demographics, race, use of nicotine products, which was very rare. Only 2%, less than 3% of patients were current smokers. The vast majority, as previously explained, did not have any prior lumbar surgery, and the prior lumbar surgeries that they had would have been at a different level. Obviously, the most common levels that these devices would be used would be L4-5, with a small number of patients getting the getting the L3-4 level implanted. But again, no significant differences between the TOPS and the TLIF groups. And the operative characteristics were also remarkably similar. The time of surgery was about 180 minutes. Length of stay was less than 3 days, 2.9 days. EBL was about the same. Basically, TOPS, in my opinion, required the same skill set, the same effort, and the same time as a TLIF. Now, people have asked me, well, TOPS does not involve the implant of a disc device. You're not putting any spacers into the disc, so it's just pedicle screws. Perhaps it should take less time, but the way the device was designed and to achieve the best biomechanical outcome from the device, the surgeons need to be quite precise in the placement of the pedicle screws, both in the angulation of the screws as well as adjustment of the screw heights. So there was a little bit more involved in placing the pedicle screws in the TOPS group, perhaps, than we normally would utilize in a TLIF group, which can be a little bit more forgiving. Mike, I'd like to turn it over to you now to go over the pre-specified primary endpoints.
Thanks, Bill. That was a great overview of the study. And again, I want to say thank you for your service for the time in the military. So when you look at the study, it was really designed to capture patient-reported outcomes, radiographic outcomes analyzed by an independent set of radiologists, and neurological outcomes assessed by those of us that participated, the patient surgeons. And you could see that it was designed to have success or failure based on success or failure in multiple primary endpoints. And you can see there's 6 primary endpoints here, and each one of those had to be met to be determined a success or a failure. So for example, to be a success in either one of the arms, fusion or TOPS, one had to have no reoperations or lumbar injections, had to have an ODI reduction of greater than 15 points, no new worsening or neurological deficits, no major device adverse events such as screw loosening, screw breakage, device breakage, etc. And on the TOPS arm, there had to be maintained motion. And then on the fusion arm, you, in the contrary, had to have no motion. So less than 2 millimeters of translation or less than 3 millimeters of angular motion in a flexion extension. And all of this was at 2 years. So again, just to be clear, you had to hit each one of these in order to be determined to be successful. So now I want to just go through the 2-year outcome data and look at those successes or failures as we get through them. So here we can see that looking at secondary surgeries or lumbar injections, there were slightly less secondary surgical interventions or lumbar interventions favoring the TOPS. And again, this is 2-year data. When we look at ODI reduction of greater than 15 points, we see a much significant or much greater difference between TOPS and fusion, with 94% of the TOPS patients hitting clinical success here with a greater than 15 points or hitting that meaningful improvement here. In fact, that difference is about 17 points. So that was quite impressive. Here, if we look at no new or worsening neurological deficits, again, you see a difference favoring TOPS. Again, it's not uncommon in the fusion, when we do fusions now, that patients do have some new tingling, maybe a little new numbness or weakness right after surgery, usually goes away. But what's interesting here in the control arm, about 11% of patients at 2 years still were complaining of such differences. When we look at major device and adverse events, you can see a slight difference here in favor of actually fusion here. And again, we define that as screw loosening, lucency, or breakage. And we look at the data here, there was one device breakage in the control arm. There was about a 1% screw loosening in both arms there, but greater degrees of screw lucency, slightly greater increased incidence of screw lucency in the TOPS arm as opposed to the control arm. Now, what about fusion status? This is motion. This was a much greater advantage in the TOPS arm with 99% of the TOPS patients at 2 years still demonstrating motion with the device, and only 56% of the patients meeting the criteria for fusion defined by the FDA. So less than 2 millimeters of translation or 3 millimeters of angular rotation and flexion extension. So that led to an overall clinical success of 73% in the TOPS arm and 26% in the fusion arm. And that's a 50-point difference well in favor of TOPS. So you can see that the conclusion here is that there's a significant advantage of TOPS over lumbar fusion at 2 years in our patient cohorts. In fact, it was so significant, the statisticians, as Bill mentioned, concluded that there was no need to enroll patients beyond the 300 patients. Again, there was a plan to roll over 500 patients here, but the interim analysis at 300, in fact, 302, showed that there was superiority of TOPS over fusion, and there was no need to go on and enroll more patients in the study. Now, the FDA requested a post hoc analysis. They wanted us as a group of investigators just to take the fusion status out, so remove that completely. So now we have 5 primary endpoints, and you can still see in favor of TOPS, even with removing the fusion status. Still a 20-point difference between that overall success score at 2 years for TOPS over the fusion. So you can see at all those endpoints, all of it favors TOPS. Now let's look at sort of the longitudinal improvement of patients over time. We just looked at baseline to 2 years. How do these patients do over time? There's some interesting data here. So here's the ODI data. And you can see with fusion and TOPS, as you would expect, again, these are spondylosis and stenosis patients, primarily leg pain. You would expect improvement. So when you look at both groups out to 6 months, they both improve fairly significantly and continue to improve as you get out to 6 months. But what's interesting here is the TOPS patients continue to improve with ODI out to 24 months. And if you look at this, less than 10 points, this is 9.4, where the fusion patients actually started to worsen a little bit over time. And I think many of us have seen that sort of phenomena where you see them early on, they're doing great. You see them at 1 to 2 years, and they may be getting a little bit worse over time. We see the same trend with the ZCQ symptom severity, where both groups improve fairly significantly out to 6 months. The TOPS patients kind of plateaued with their score, while the fusion patients worsened to some extent out to 2 years. Same thing with ZZQ physical function, where both groups improved fairly significantly out to 6 months. The TOPS patients somewhat stabilized, and the fusion patients began to worsen just a little bit after 6 months out to 2 years. Patient satisfaction favored TOPS at all time points. And as you would expect, if the symptoms got a little bit worse over time in the fusion group, the satisfaction actually worsened a little bit at 12 to 24 months in the fusion group. And that was not seen in the TOPS groups at 12 and 24 months. What about VAS back pain? Same trend as we saw before. Improvement in both groups out to 6 months fairly significantly, but somewhat worsening back over time in the fusion group with regards to back pain. So you can see here that in this study, all of the primary endpoints we look at favor TOPS. Patients improve longitudinally over time, and the outcomes far favored the TOPS over the fusion in these cohorts at 2 years and longitudinally through time. So let me stop here. Let me turn it back over to Bill and ask him to go over the safety and motion data. Bill, let me kick it back to you.
Mike, thank you very much. Just superb outcomes, beautifully presented. So I'll just continue on with regards to safety and motion evaluation. And it's important to point out that, of course, all the radiographs are independently reviewed by Medical Metrics, which is a company that's becoming, which is very commonly used in any of these trials. It's completely independent. and very precise. And it's their outcomes have been validated over the years in multiple trials. So I'll review the adverse events, the serious adverse events, as well as the motion evaluation of the TOPS trial. And as you can see, just an overview, which you'll see in the next few slides, is that generally speaking, TOPS does better than the TLIF fusion with regards to adverse events. And if you look at any device-related adverse event, it's 21% in the TOPS trial versus 28% in the fusion trial. And again, this was a 2-to-1 randomization, so more patients have received the TOPS device, but the percentage points out that the likelihood of any device-related adverse event is lower in the TOPS device than it is in the TLIF group. And again, any fusion-related, any procedure-related adverse event is also lower in the TOPS group than the fusion group, and any device and/or procedure-related adverse event remains lower in the TOPS group than it does in the TLIF group. This next slide is highlighted in yellow, outlining complications that occurred with a 2% rate or higher to eliminate the much rarer complications. And I do want to point out that categories are quite interesting, especially in terms of pain. If you look at pain from any source, you'll see that the TOPS patients report less adverse event with regards to pain than do the fusion patients. Interestingly, and a little bit surprisingly, also with regards to back pain, the group that got TOPS reported a back pain as a notable adverse event at 11%, whereas the patients had a fusion, it was reported at the 21%. Adjacent segment degeneration was not identified in the TOPS group, but was identified in the fusion group at the rate of 5%. I think that's very well in keeping with the literature. Dural tears were higher in the TOPS group, and I believe that this is related to some of the technical difficulties, some of the technical components about putting the TOPS device in and the precision that's required. And again, I already covered arthralgia, back pain, musculoskeletal pain, paresthesias. Mike, as you pointed out, about 5% in the fusion group, only about 2% in the TOPS group. And pedicle screw loosening. So this is the group that required treatment, about 1% in the TOPS group and about 2% in the fusion group. So it's a lower clinical rate of screw loosening in the TOPS group versus the fusion arm. So just to go into that in more detail, I prefer the phrase loss of the bone screw interface as opposed to screw loosening, but loss or reduction in the bone screw interface as reported by the investigator was 1% in the TOPS group and 2% in the fusion group. And these are patients that were treated for this problem. The radiographic lucency, that is to say, medical metrics reporting loss of the bone screw interface, perhaps a halo around the screw, which was, of course, independently assessed by medical metrics. In the TOPS group of patients, it was about 7%. None of those patients underwent reoperation, and 5 of those 7 patients would have been determined or were determined to be clinical successes at 24 months. So I think it's important to point out that while you can have some loss of the bone screw integrity, the patients are still usually a success. Now, Mike, I think you were involved, and certainly I was involved in the Genesis trials. Again, non-fusion, instrumented trial, and the loss of bone screw interface in that trial was anywhere between 3 and 17%. And the screw loosening, that is to say, loss of bone screw interface in many fusion trials is between 5 and as high as 20%. So I think that what we're seeing is very well accepted and probably better than most of the reported literature with the TOPS device. With regards to serious adverse events, TOPS device reported, as I said earlier, 4.3% serious adverse events, whereas the fusion group had the 5.3% serious adverse events. And again, any adverse events were less common in the TOPS group than they were in the fusion group. So the TOPS arm again did at least as well as, but usually better than the fusion arm with regards to adverse effects. Finally, you can see a distinct advantage for TOPS in terms, when compared to fusion, in terms of reoperation. If you look at the overall reoperation rate in the TOPS group, it's 5.3%, so 1 in 20 if patients had a reoperation for any reason in the TOPS group. If you look at the overall reoperation rate in the fusion group, it was 8.5%, which I think is about 1 in 12 patients underwent a reoperation in the fusion group for any reason. The reasons most commonly in the fusion group would be, as you would expect, adjacent segment disease, but also pseudarthrosis and occasionally durotomy. TOPS group, the more common cause was wound complications, retained surgical drain, and durotomy. There were two patients, I believe, in the TOPS group that had an unrecognized dural tear that required reoperation. There was also one misplaced pedicle screw in the TOPS group, and I believe there were no misplaced pedicle screws in the fusion group. So again, complications as one might expect based on our knowledge to date and the pre-existing literature, but TOPS clearly a winner with regards to subsequent surgical intervention for any reason. Now, with regards to motion, TOPS also, as we would hope, is able to maintain the patient's motion in lateral bending and flexion and extension. So this did not bring motion to normal, but it did maintain, for the most part, the patient's motion, as you can see in the graph, in lateral bending. Whereas fusion, as you would expect and hope, obviously reduced the patient's motion, lateral bending. Flexion extension was preserved again in the TOPS group, and as expected, lost in the fusion group, as was maintenance of translation. So I was pleased to see this, a little bit surprised, but you would certainly expect fusion to control for translation. But as it turns out, the TOPS device itself also actually improved translation over the course of time. So it did not worsen the patient's translation, despite the fact that the patients had a very aggressive laminectomies and facet resections. So I think that speaks to the robustness and the design of the TOPS device. So TOPS was safe, effective, stabilized the spinal segment, and maintained motion postoperatively. To me, anyway, this device and this group seems to be a very viable alternative to lumbar fusion, again, in the group that was studied, which was degenerative spondylolisthesis with moderate to severe spinal stenosis, more leg pain than back pain. And with that, I'll say thank you. Turn it over to you, Robin.
That was extremely enlightening, all-encompassing, and I want to commend you both and your co-investigators for investing, I think it was 5 years, to study facet replacement and its utility for treating spinal stenosis and spondylolisthesis. There are some immediate questions that come to mind, and I did share one of the first ones with you ahead of time, and I wonder if we couldn't look at the next slide. Most clinicians, I think, are familiar with spinal stenosis and spondy literature. Specifically, the New England Journal of Medicine published conflicting conclusions on the benefits of fusion versus decompression only for this particular patient population. So Mike, the question is for you. When you put the TOPS trial results side by side against the SLIP-1 study and the Scandinavian studies, you see a big advantage to the TOPS trial. In your mind, how would that be explained? What would cause that?
Thanks for the question. And it's interesting if you look at these studies side by side, as you mentioned, and just note the differences between the group. Because if you look at the three studies with regards to fusion or decompression, they're fairly similar results. They all end up about the same, maybe 20 points, 25 points at 2 years. But if you look again, what you just brought up with TOPS, much greater difference with TOPS, 48 points and 35 in the fusion. So, how do you rectify that? And let's just look at this a little bit different. So let's look at more or less their baseline scores and see where these started from with regards to where they started, where they ended, more or less, with regards to all these studies side by side. So here is the beginning scores, right? So here's the entry scores for both the decompression and fusion at the 3 studies, the Swedish, Norwegian, and SLIP studies, and then here's the TOPS. You can see a fairly significant difference between the starting points between those studies, the 3 studies, regardless if it's decompression, fusion, or TOPS. So the difference is pretty dramatic. It's more than 15 points in each one of these. So what this showed is that in the TOPS study, we actually enrolled patients that were more severe with returns to their preoperative disability than you saw in any of the studies that are out there. And so here you got a sicker population or more severe disabled population in TOPS, and you look at where they ended, right? So here's the outcomes, as I mentioned before. So decompression and fusion, maybe gets you around 20 points, maybe on average with regards to fusion or decompression across the board if you just average these out. So it didn't matter if you got a decompression or fusion, you had some improvement, but you only ever ended up about 20 points. But if you look at TOPS, it was the only study that was really able to get that disability score below 10. So, down to 9 points. So this is a fairly significant difference if you look at that difference between pre-op to post-op. So why do we see it? We see it because we enrolled patients that were worse off to start with. So you're going to see a bigger delta here. So that's the simple explanation of why we see such a difference in the delta or the change between pre-op to post-op ODI. But still, if you look at our fusion group, it still ends up, even though they started off worse, they still get about the same as the other studies across the board, decompression or fusion. And really TOPS is really the only treatment out there that was able to get a fairly significant ODI and get those patients less than 10 points. Just showing the benefit of facet replacement in here over over fusion or over decompression.
Great. That's wonderful. We do have another question here. The fusion outcomes in the study were, I guess, surprising at first blush. How does the fusion control in the top study perform or compare relative to other large IDE studies involving patients with this kind of lumbar pathology?
Sure. Yeah. So again, Rob, another great question. So if we look at sort of where TOPS fits in on the fusion side at 2 years compared to a couple other IDE trials. So this is Coflex, Protoscale, and DenaSys. So how did the TOPS fusion perform there? And you could see that the fusion success rate is similar to those other studies, but didn't perform quite as well in some areas as we saw the other FDA studies. And again, as you mentioned, how do you rectify that? Like, why would there be differences in the fusion cohort in TOPS versus others? And I think it has to fall back onto my very first slide, which is that composite score of success. So we had a fairly stringent definition of success with fusion, which is hitting all 6 of those endpoints. And if you miss just one of them, you're deemed a failure. When if you look at the definition of success in the other studies, they didn't have all of those with them with the overall combined. They may have used 3 primary endpoints when we use 6. So again, it shows that that's probably the explanation why we see a difference between TOPS and the other studies. It's really that stringent definition of success we used compared to the lower bar, so to set, for success of fusion in the other cohorts. But again, I do want to go back to that post hoc analysis. When we looked at the success of fusion, the FDA said, take fusion out, right? Forget that for a second. How do your patients do? And even when you take fusion out, the outcomes were still far in favor of TOPS over fusion, still by 21 points. Again, just showing, I think, the advantage of these facet replacement, or this facet replacement system in this cohort over fusion.
I'd also argue that shows the advantage of a well-designed study. I mean, as I looked at the study immediately, I noticed how great it was put together. And as you lay out these other studies along with it, I just reminds me again. I mean, I go back to the Dinas era as well, how much we've learned and how much it seems to me this study we baked in a lot of the things that we've learned. Bill, I do have a question for you from the audience. And it really has to do with how complicated the TOPS surgery is. It doesn't appear to be that complicated. I don't know. It seems fairly straightforward. What's the learning curve like?
Well, it's a very good question. I would tell you, Robin, there really is no learning curve if you look at it statistically. That is to say that the surgeons took about the same amount of time and had about the same amount of success with their first case as they did with their last case. And the patients had about the same overall composite clinical success. I will tell you this, I think I did about 30 cases or so. The placement of the instrumentation has to be very precise. We can be a little bit less precise when we're doing the interbody fusion, because that's another column of support. But to get the maximum benefit from the TOPS device, the screws do need to be placed precisely. The screw angles need to be precise, and the screw alignment and height of the screw heads needs to be precise. This way, when you're putting the device in to the patient, you're not preloading it, and you're able to obtain the maximal motion preservation for the patients with regards to what the device has to offer.
You know, again, I'm still mulling over this the study design, and I noticed that one of the secondary endpoints had to do with opioid use. Seems to have come down fairly significantly. It appears to be impressive. But Bill, from your perspective, how did that look in your end?
It looked just like the chart. It was tremendous. The fusion group decreased in their opioid use by about a third. The TOPS group decreased in their opioid use by about a half. I think this is directly related to my earlier slide, which showed the adverse event slide, which showed that the patients were generally having less pain in the TOPS group than in the fusion group, including less back pain. So I have to say that opioids are a major problem in the US. It was this was consistent, and it was very pleasing to see how much less opioid the TOPS group was using overall.
Fantastic. And now, a very important point, patient selection. There is a question from the audience about the types of patient that TOPS might be best indicated for. Would you use TOPS on stable or unstable spondy patients, or how would you characterize it? And I guess, Bill, if you don't mind, why don't you tackle, and Mike, if you don't mind, come in after that.
The patients had to have degenerative spondylolisthesis to be enrolled in the trial. So I think that's and single level degenerative spondylolisthesis to be enrolled in the trial. Again, more leg pain than back pain. So I think that's important to keep in mind. However, the patients frequently, as part of the decompression, they had a lot of the facet joints, in some cases, basically complete facet joint resections performed, wide decompressions, wide foraminotomies, and I'm certain in many instances the patients had iatrogenic pars interarticularis defects created by the surgeon, just to make sure that the decompression was as wide as possible. That group, I think by anybody's criteria, would then be an unstable spondylolisthesis. But despite that, those patients that I think we would term would have an unstable spondylolisthesis did really just as well as the patients who had a stable spondylolisthesis. So you can see in the graph that the TOPS patients achieved significant and sustained improvement in ODI, regardless of the nature of the pre or intraoperative instability.
Yeah, and Robin, when you look at the study design, it was really designed to enroll stable spondylolisthesis patients. So that's really what our baseline was. But as Bill just said, it was really surprising in that these patients post-op, did have some evidence of instability, or we had some unstable spondies. If you look at the definition of that, rotation greater than 5 degrees, translation greater than 3 degrees. And I initially would have been worried that perhaps the device would not function as well in those patients. And here we can see that those patients actually did equally as well as the stable spondees, all the way out to 24 months. And so, really wasn't designed to answer the question of what degree of instability would the device work well in. But I think it's a little bit surprising and also very reassuring that in those patients, which is like the 85 to 90% of the patients we see, which are completely stable or maybe just have a slight degree of motion, that the device seems to do equally as well with regards to outcomes as a complete stable device. So surprising, but I think reassuring for those surgeons that are out there that are worried about this not providing stability in spondy, that not only do we prove that it does, but also in those with slight instability, it continues to provide that stability. So it should be reassuring to people that actually look at this device and look at this study as well.
I think what is also reassuring is that we had you two leading the charge on this study. And again, I have to add my congratulations to Premia Spine and Ron Sacker for just persevering, finding the funding, and getting a great study done as it should be. And we are out of time. I do want to thank you again, Dr. Welch, Dr. Steinmetz. This has been a wonderful masterclass with really the best faculty anyone could hope for. Have a good evening, and thank you everyone for attending. Take care.
Thank you, Rob.
Thank you,
Thank you, everybody. Thanks, Bill.